Did you guys have a good pair of micro labs? You got nice and relaxed. Who had beer? All right. So I wanna build on this momentum, this light, exciting feeling that you've got by talking about something that I think is going to thrill each and every one of you, and that is large-scale institutional procurement. Does that sound exciting? All right, we'll do our best. So I'm Jaspal Sandhu. I'm co-founder of an innovation consultancy called the Gobi Group. We do work in social impact. We're about 5 years old. We have a global health portfolio. We do work in public health in the US as well. We do work in education, a few other areas. I also teach a innovation course, graduate innovation course at the University of California, Berkeley, where I'm on faculty at School of Public Health, which if you're interested, talk to me about it afterwards. We bring together MBAs and journalists and computer scientists and all stripes of public health to work together on really practical issues from an innovation perspective. I'm going to talk to you today about procurement of HIV drugs specifically. So, who does work in HIV? Okay, wow, that's a lot of you. That's like half the crowd. So, this should look familiar to most of you. These are global numbers for the gap in HIV treatment across the subregions of Africa. So for those of you who don't work in this space, here's the big picture. For the past 12 to 15 years, we have, as a global community, and that includes a lot of national governments and a couple big funders, Global Fund and PEPFAR, have been working to increase access to HIV treatment worldwide. We got very close, I think. We got up to about 55% in 2013 in the Africa region. And then WHO guidelines came out in 2013 and expanded the number of people, the criterion for which people would be brought onto treatment from 350 to 500 CD4 count. And what that means is now only 1 in 3 people in sub-Saharan Africa is receiving the treatment that they need. Not everybody that has HIV is eligible for treatment, but 1 in 3 is receiving treatment. Treatment costs have come down considerably, but we have to figure out a way to close that gap. And this is so a brief primer on antiretroviral treatment. Generally, when we are talking about global antiretroviral treatment, we're talking about a cocktail of 3 drugs. Different drugs can fit into those slots, but somebody is always taking these 3 drugs. And so when I talk today, I'm going to be talking about adult treatment. I'm not going to be talking about children. I'm not going to be talking about PMTCT, which Michael from Pfizer talked about earlier. Not that we don't think those are important, not that we don't work on those, but just to keep it simple, we're going to talk about adult treatment. So you can have 3 drugs, and those 3 drugs can manifest, and they come in pills for adults. They can manifest themselves in 3 tablets, or 2 tablets, or 1 tablet, and that's really important for adherence. This is where we play. It's a little blurry, but it's probably better that it's blurry. This is a framework for how FGON, so Federal Government of Nigeria, does procurement. I'm not going to talk through it. This is complicated, but this isn't even what we touch. This is just an illustration of how complex things can be from funding sources, from implementing agencies, from procurement bodies, and from people that are actually bringing drug to port and from port to country distribution sites. This is a really complex decision space. So countries are getting money from their own coffers, from Global Fund, and from PEPFAR largely. Those are the 3 big sources, and are then tasked with making decisions about which products to buy, so not just which drugs, but which products, which formulations, from which manufacturers, at what price, in what quantities, at what time. And once you factor in things like clinical adherence, or the fact that having 2 pills might be way better than having 3 pills, but the 2 pills cost 17% more, you begin to see that this is a very complex decision space, and that you can have things can go awry. So this is an example that is highly anonymized. This is a very sensitive issue for countries. For those of you familiar with geography, you'll notice that this is not an African country. This is North Carolina, which is where we are. The country, and these are real numbers, adjusted ever so slightly to mask, even further mask the identity of the country. Country with the same population as North Carolina, plus or minus, in 1 year, buying a single product, a 2-drug FDC, fixed dose combination. So it's a pill that's got 2 drugs in it. They purchased about 30 different times they purchased this single product and overspent by $5 million. North Carolina is not a big state. Pop, how many people we have here in North Carolina? You know, who knows? Come on. 9 million, so that'll give you a sense. That's a tremendous opportunity for improving this decision space. It's not always about getting a better price. Sometimes it's about picking the right product. Sometimes it's about the right quantity. Sometimes it is about switching regimens. But it's just, let me just say it's a complex decision space. So we partner with the Clinton Health Access Initiative. What Clinton Health Access Initiative does, and has been doing for the past nearly a decade, is they send really bright people as consultants. So these are usually people they've sourced from graduate programs or from McKinsey or Bain. They come to work for CHI, they get some crash course on their global health training because they're not always global health or healthcare experts, and then they become embedded in countries. So they might be sitting in Nairobi, they might be sitting in Bangkok, they might be sitting in Lima, in Pretoria, and they serve as consultants to the government. And the teams that we work with at CHI are focused on one very specific thing, that is helping countries make more cost-effective decisions around these purchases of drugs. So large purchases, right? So talked about here, this is 5 million on a single product. We have hundreds of potential regimens, dozens and dozens and dozens of products, about a dozen or so manufacturers. That's just one product. They spend a lot of money, and there are huge potential opportunities for taking that same money and stretching it further. So if you look at this, $5 million, that country that's like North Carolina in size could have translated that into about 30,000 adult treatments for an entire year with the same product. Think about that. That's already money. I mean, I know a lot of you, who deals with bureaucracy in some way, shape, or form? Everybody should be raising their hand. You know that money was already earmarked to buy product. And I know there's other aspects. There's, you got to talk about in-country delivery, you have to talk about education programs and all this, but that money was already earmarked for product. So we were brought in a couple years ago to work with CHI and to look at this problem and figure out how they could extend their reach. And we do design work, we do innovation work, a lot of our work is around technology, and we landed on this, Optimize ARV. It's, maybe the logo looks sexy. I think the actual product is not that sexy. I think it's really critical. I think this might be one of the biggest plays in HIV that we've seen in a while. I know it's very arrogant to say, but I really think this is important. But it's not mobile. It's a web-based platform, a data platform that helps countries make more cost-effective decisions around these big procurements. So this is what it looked like. It took, Ken talked this morning about Ushahidi and how it's built in 4 days. This is a proof of concept. It wasn't built in 4 days, but it was our team and we built it quickly. It was built in a couple months. There were a couple reasons that it took a while to get the ball rolling again. I think also touching on some of Ken's comments about development, but the ball is rolling again. And this is what we've got now. This is how I like to talk about it, is we're creating a turbo tax for ARV procurement. So I live in Oakland, California, and that's, it's close enough to say I'm from Silicon Valley. Right now, everything is called an Uber. If you don't know what Uber is, it's too complicated to explain, but definitely find me or find somebody and I'll explain it afterwards. It's gotten so nutty in the Valley that even Uber has called one of their new products the Uber for package delivery. So I bet the media would eat it up if I called this the Uber for ARV procurement, but it's not true. It's TurboTax. And that would have been really awesome to say in 1998, but it's 2014 now. But the reason we use TurboTax as an analogy, I'll also explain TurboTax for any international visitors who are like, what are you talking about? TurboTax takes a really complex thing that nobody really seems to understand, which is our tax code, US tax code, and makes it accessible for all of us. It masks the complexity, but it doesn't tell us what to do. It preserves choice and agency. So TurboTax is not deciding my taxes or your taxes if you use it. It is helping us make easier decisions in a stepwise manner. It's preserving that, and it's kind of extending our capabilities. And that's really what we're aiming to do with Optimize ERV. So big picture is, we built this thing really quickly. We rolled it out in a very select way to particular people in particular organizations. It was a big hit. It took a couple years to get the ball rolling again. We got the ball rolling, and now we're building this, and we're going to be rolling it out to 2 countries that David also knows I'm not allowed to say the names of because of political sensitivities, but they're real countries. They're not like that North Carolina place. And we'll be rolling them out in the 3rd quarter this year. And it's very intentional of us to work with those 2 countries very closely, because we want to, one, work with countries and teams that already have demand for something like this. Again, touching on some of the comments from this morning is, you just want to build a product. You want to build a product that really is going to stick. So I wanted to do a couple things with this. One is I wanted to give you an overview of what we're doing with Optimize ERV. The other is I wanted to focus on some unique design considerations, because Heather, and thank you again for inviting me, Heather, there you are, asked me to talk about humanitarian design. And I thought about this work, and Optimize ERV is not all that we do, but we definitely come from a very strong human-centered design perspective. There are a couple things about this effort that have really made me rethink some of what we're doing with design. It doesn't mean that, this applies in every case. It's just that it's more that the approach should, as we all know, in our heads and hearts, should really match the problem. One is, after that long pause of a couple years, we were at a crossroads where we could go down this path. We could take what we'd already built, which didn't take long, but was pretty sophisticated. We knew that there was demand for it, people would use it, and frankly, from a business perspective, because my company operates as a business, would have been much easier to do. Just say, just carry it forward, move it on, people will use it. The other was to scrap it completely, to use a housing analogy, like knock it down to its foundation and then start all over again. We opted for the latter. It was a painful decision to make from a business perspective, but it was, I think it was the right thing to do, because this is not, this is certainly part of international development, but for those of you that do work in, let's say, marketplace work around drugs, you realize that it's a very interesting hybrid, public, private, sometimes with a dash, sometimes with a wall between it, space, and the marketplace had changed. Simple things, for those of you that are in HIV and will know what I'm talking about, is access to globally negotiated ceiling prices. That was a huge opportunity. That's actually where a lot of that $5 million went in 2010. Now, most of the countries are accessing those pricing lists, so that's not an opportunity. But there are plenty of other opportunities in terms of regimen changes, in terms of product selection, that are going to save big dollars and be able to translate those dollars into additional treatment. So we started from scratch, and I don't need to talk through this, but this is the new framework. It's lookups, benchmarking, and action analysis are the 3 modes. We should talk about it. Lookups is just easy access to information. Benchmarking is comparing yourself to other countries. Action analysis is more sophisticated stuff that looks a little bit more like, if we do switch to this new regimen, what are the budget impacts going to be? And lookups, getting back to not being sexy, lookups is providing access to information. It's, in some cases, providing access to, say somebody at a central medical store wants to know whether a product is registered in their own country. They can make a call over to the ministry, to the National Drug Regulatory Authority. These things look different in every country, and they can get that information, but it takes a really long time because information sits on paper, or there's only one person responsible in a small country, and sometimes there are reasons to guard that information, sometimes it's just hard to do because people are overwhelmed. So what these people do is they will contact Clinton Health Access Initiative, and sometimes they'll contact their global teams in Europe or in the US to get access to information that's literally down the hallway or down the street. 2, we are designing for astronauts. You guys know what astronauts are, right? Okay. So with a lot of our other work and with a lot of stuff we've seen today, we're designing for, like we do work with community health workers, we're designing for tens of thousands of people or hundreds of thousands, and we're really talking about massive scale. this is different. We're designing for about 50 global users. We're putting a lot of effort, maybe 100. We're putting a lot of effort, but we only have 4 people that we care about in each country. And we're trying to provide them with access to these tools because they're the ones that are making these decisions. It might be somebody who sits on a forecast or a quantification team. It might be somebody that's in a technical working group. But it's just a very small number of people that are making a relatively small number, taking a relatively small number of actions, say a few hundred in a year, say 200 in a year, 100 in a year, and we want to inject ourselves into that. You know, there's a lot of other tools in the HIV space that sit on the web that are kind of all over the place. They're not really targeting anybody. They're supposed to be general purpose tools. I'm totally fine if this thing has very little public face. We just need to inject it into those particular individuals and processes. And though it might be against the rules to say this here, we're not building any capacity. We do with our other work in some cases, but I feel very strongly that it's, you know, we talked about respect in a couple of different ways today. Like in this case, the right way to respect people who work on these teams who are already overburdened with too much to do is not to train them how to do this analysis that CHI's country teams are doing, is to provide them tools that do it for them. So out of respect to the CHI teams and out of respect to these countries is to provide them with tools rather than to provide them with training. So anyway, those are 3 things I thought that were pretty instructive to us as we've gone through this process and sort of reframed how we've thought about how we do human-centered design. If you have any questions about what we're up to and what's going to be coming next, where we're working possibly, you can find me offline. You can also contact me here. I should also say that this work, as it's been restarted, has been funded by UK Aid. So thank you all. Appreciate it.